Our theme on emergent care and community has covered all 4 fields of anthropology. And I would just like to let you know what our overall programming is covering for the academic year. The global pandemic has highlighted the irony that care workers are often underpaid or even unpaid, their exploitation a symptom of structural inequalities accrued across generations. Against the centrifugal forces of capitalist modernity, what possibilities exist for radical mutuality in the future? What constitutes care as related to the social, environmental, ontological, or material? Rather than asking anthropologists to assume some kind of prophetic role, this series offers an opportunity to take critical stock of what tools and perspectives our discipline provides in terms of methods, theory, community engagement, and public commentary, as we envision and imagine new possibilities for reshaping society. We are mindful of the crisis in Ukraine, recognizing that this is an urgent iteration of imperial criminality that so many communities have suffered at the hands of subjugating powers. We seek to understand and engage in forms of care and mutuality that oppose and redress the injustices of all imperialisms, past and present. And with that, we turn over to our speakers for tonight. Christina Baines, who is my co-chair in the New York Academy of Sciences Anthropology section, will do our introductions tonight. Christina?
Good evening, everyone. We are very excited to welcome 3 amazing scholars tonight. Our featured speaker is Dr. Robin Nelson. She's an associate professor in the School of Human Evolution and Social Change at Arizona State University. With a focus on critical periods of growth and development, she investigates the relationship between familial dynamics, culturally salient forms of social and financial capital, and the health of Black Caribbean families. Her work engages with research in cultural anthropology, public health, gender studies, and Black feminist studies. She also investigates equity in science and the legacy of racism on theory building and biological anthropology. She received her doctorate from the University of Michigan in 2008, and then completed a postdoctoral fellowship at Northwestern University in the Laboratory for Human Biology Research. Dr. Nelson was most recently a faculty member at Santa Clara University before arriving at ASU this fall. And we have 2 discussants in conversation with Dr. Nelson today. We have Dr. Luseadra McKerracher. She is currently a junior research fellow at the Aarhus Institute for Advanced Studies and an incoming assistant professor in the Department of Public Health, both at Aarhus University in Denmark. In Denmark, she is leading a community-based health promotion project called Supporting Pregnancy Food and Nutrition Security, or SPOONS, in Denmark's most marginalized neighborhoods. SPOONS focuses on identifying and measuring household food insecurity, real or perceived lack of affordable, healthy, socially appropriate food in social housing blocks with primarily new immigrant populations. SPOONS also aims to work with local organizations to mitigate food insecurity for households with pregnant people or with parents likely to start a pregnancy in the near future. In addition to SPOONS, she's involved in a number of other health equity related studies in Canada and Denmark, all focused on investing through care in preconceptional pregnancy and infant health to support equity in health and well-being in the next generations. We also welcome Dr. Aunchalee Palmquist. She's assistant professor in the Department of Maternal and Child Health at the UNC Chapel Hill Gilling School of Global Public Health. She's a medical anthropologist who examines the biocultural dimensions of perinatal health inequalities. Their recent work focuses on the ethics of postpartum newborn care in times of crisis, including humanitarian settings, the COVID-19 pandemic, and incarceration. We're very fortunate to welcome these 3 scholars and look forward to our discussion.
So first I want to begin by really thanking the New York Academy of Sciences for inviting us to speak today. And I would like to thank Luseadra and Aunchalee Palmquist for being with me today. As calamity upon calamity seem to pile up, there have been musings that this is the end of the world. There's even a TikTok meme asking why everyone is working so hard when the world is clearly ending. As anthropologists, we tend to think in deep time, millennia rather than decades, millions of years rather than centuries. And as such, I began to tangle with my own experience of this moment as a scientist, as a Black woman, as a mother, and even as a Gen Xer who has lived through my fair share of personal and public tragedies. As someone who is keenly interested in the human condition and experience to the level of obsession, really, as I've dedicated my professional life to this, I began to wonder how the general public, non-scientists and non-anthropologists were experiencing this moment and what reference we have for relatively non-biblical conversations about the end of the world. And I say non-biblical because we have lots of references in the Bible, surely. To this end, I asked myself, what has pop culture told us about the end of the world? In most cases, there are several causal elements that appear in these pop culture pieces, and I'm particularly thinking of film right now. There are changes in weather, like The Day After Tomorrow, the film from, I think, 2004. There are despotic rulers, like The Hunger Games. And there are also viruses, as in all the above noted zombie films. Zombie films, in fact, I couldn't help but continually return to the genre of zombie films. Just hang with me for a second here. Zombie films provide this fascinating window into our own fears and vulnerability. In almost all zombie films, there is some contagious element, a virus most often, that renders individuals susceptible to losing their lives. There is also a recognition that you have to run and hide and dodge and protect oneself from this impending danger. And finally, zombies themselves are terrifying, even when zombies move slowly, because they lay bare what happens when society can no longer function as it once did and danger is around every corner. Whatever the causal catastrophic elements, whether despotic rulers or a virus, these films remain relevant and scary and prescient because they challenge our ideas about normalcy, our beliefs about our ability to remain safe, and they ask us what we would do at the end of the world. In February 2020, I was teaching a class called The Biology of Poverty when I started hearing word of a virus that emerged in Wuhan, China, and was spreading rapidly and causing high levels of illness in the communities in China. Because this class was in part a lesson on risk and vulnerability and health outcomes, I began mentioning it in passing to our students. During the first weekend in March, I went to Target and began stocking up on Advil and ibuprofen, hand sanitizers and masks, and non-perishable foods. And when I was checking out, the cashier said, "You heard, huh? I did some early morning shopping at Costco earlier last week." Then on Tuesday, March 10th, 2020, I remember saying to the class, "We are not getting out of this unscathed. Please begin to mentally prepare yourselves for this to disrupt your life." I never met with them again in person after that meeting. The next day, our campus went virtual, and for those students, many of whom were seniors in college, their worlds changed irreparably. No graduation, no parties, no senior celebrations, all things that may seem minor or trivial, but do serve as those place markers for the passage of time, the completion of a daunting task like college, and places your life, or their lives in this case, in relation with others who have experienced the same thing. We know that beginning in this moment, and I use these pictures here of the Champs-Élysées, London, and Dumbo in Brooklyn, because they actually draw us back to those pictures from the zombie films where the streets were absolutely deserted. In only a few weeks, cities around the world began to quote unquote shut down. There were scenes of deserted streets that in our lifetimes were once only the manifestation of a creative art director on a film set. And these became eerily normal. New York, a place that we call the city that never sleeps because it literally hums with energy and noise at all hours of the day, suddenly became a space where folks reported hearing birds during the day outside of green spaces. Is this the end of the world? If so, whose life was made less typical during this time? Who was no longer traveling out to work and who still had to? how did we make sense of this new space, which we knew was liminal, but whose liminality was unknown? Would this be our new normal for 2 weeks, for 2 months, or 2 years? And is there any precedent for this kind of shift in social organization? When I wasn't wrestling with 2 children who were suddenly attending school from home, these questions dominated my thinking. If we turn to the archaeological record, we can learn a bit about what the end of the world, quote unquote, looked like in our human past and what preceded, devastation and what emerged afterwards. In one case of the site of Tikal, which is in Guatemala, it was at its height from 250 to 600 CE, and by 900 CE, it was completely abandoned. After hundreds of years of prosperity, the Maya left the city of Tikal, and some of the reasons for desertion were overpopulation, persistent droughts, and overexploitation, deforestation of the surrounding land. And in fact, a recent study by David Lentz and colleagues found the presence of toxic algae, an algae which may have flourished because it was nourished by phosphate which accumulated in the reservoirs due to centuries of smoky cooking fires and ceramic plates washed in the reservoir, that this dominance or rise of algae and mercury metals probably made the water in the reservoirs unhealthy. So between the waters in the reservoirs becoming unhealthy and the land becoming deforested, the entire area became uninhabitable. These areas, which were empty relative to the previous population by about 900 CE, were not resettled. There was a reorganization of the community that once lived in this space around lakes and rivers, and migration from the southern lowlands to the northern lowlands and to the highlands. And I bring up these particular cases, and I'll give you one more archaeological case in a second, because I want us to think about what we mean when we say it's the end of the world. What is ending and what happens afterwards? Cahokia also gives us a really interesting example, both of these cases draw really interesting parallels to what we're experiencing now. Cahokia for a long time was a classic example of what folks called collapse. And it took up a lot of space in a kind of apocalyptic imagination within anthropology and archaeological anthropology. Cahokia was an enormously large settlement. At its height, it was the size of London or Rome with regards to population. And it had an explosive population at the confluence of the Mississippi and St. Louis rivers around 1,000 years ago. And over a 100-year span, it grew to one of the biggest settlements in the world. Over time, though, the countryside is reorganized to provision the city with deer and corn, and inequity builds as the people in the city center are healthy, but people in the countryside show signs of increasing malnutrition as their diet shifts towards more squirrels and turtles and away from deer. During the next 200 years, the city had to build a stockade around it and the elite quarter for one of the outlier settlements in what is now East St. Louis, because it is one of the elite quarters, is brutally attacked and burned to the ground. Then within the archaeological record, I'm sure it was not sudden for the people who lived there, but if you're looking from kind of archaeological time depth, there's a kind of sudden depopulation with the Cahokia elites seeming to flee down to Alabama, where they try to rebuild the city at Moundville, but it never reaches more than about 1/10 the size of what Cahokia was, with most people dispersing into smaller, more egalitarian groups, revealing evidence of better health and lower violence. And this is a kind of interesting site because the whole central ceremonial palace is very much like a Mesoamerican city with a grand plaza with pyramids at either end, a henge for celestial ceremonies, and a layout planned around the movement of the sun across the annual cycle. But this was all built on the backs of individuals who were exploited and eventually rebelled. So from the archaeological record, what do we know about the end of the world, quote unquote? Well, we can think a little bit about resource accumulation and resource accumulation in particular parts of the community, whereas others don't have access to these resources. So that manifests itself in inequity. And we can kind of think about this through a kind of structural violence lens. We also see shifting norms and expectations, which are sometimes codified, as in the case of Cahokia, when people who were in the farming outlands were expected to provision people in the city. And then eventually we see a dissolution of society as it was once established. The case of Tikal in Guatemala is particularly prescient as we are now navigating our own challenges regarding climate and sustainability. It seems that when one looks in nearly any direction, there is evidence that the climate is changing and it will change our lives in irreparable ways if we don't act immediately to meet this challenge. Recent findings from the International Thwaites Glacier Collaboration, funded by NSF to the tune of $25 million, identified cracks and fissures in the Eastern Shelf. If it collapses, the rest of the West Atlantic Arctic sheet could collapse, raising tides around the world. And is stated in the Rolling Stone article about changes to this ice sheet entitled, quote, "The fuse has been blown and the doomsday glacier is coming for us all." We would need to say, quote, "goodbye to every low-level coastal city around the world." Additionally, the news, or I should say this news regarding the shifts in Thwaites Glacier is not surprising in light of news from the EPA regarding their climate indicators. As you can see from this graph of annual average temperatures in the lower 48 since 1901. We can see that beginning around 1970, 1980, we start seeing increasing temperatures. And then you can also see measurements from the lower troposphere, which is the lowest levels of the Earth's atmosphere, and those temperatures are rising as well. In actuality, few of us need meteorological data to identify changes in local temperatures. If you look at this map, which provides similar evidence in surface temperatures taken in 30-year increments, beginning in 1901 to 1930 and ending in current day, I'll show you the second one in a minute, you can see that what was areas that were once cool are increasingly hot. And I think we've all experienced that. Okay, so what of those moments and how does this speak to our conversation about the end of the world? Well, just as we've seen in the past and with many other cases, the end of the world is not experienced equally. And everyone does not experience the trauma of this event to the same order of magnitude. The rising temperatures are experienced by working class and poor people differently than their wealthier counterparts, who may have jobs that allow them to work inside air-conditioned buildings, allow them access to fresh and cool drinking water, provide them with appliances that allow them to cook and clean clothes in cool areas and without physical labor, and provide resources to escape the heat if needed. In the US, the effect of urban heat deserts is intensified in poor communities, where there are fewer green spaces and thus reduced ability to mediate increasingly rising temperatures. This graphic highlights cities with the strongest correlation between heat and income. So the darker the green color is, the higher the income, and the light green are lower incomes. And then dark red correlates to heat, increased heat, and lighter red to cooler areas. And you can see how closely it maps on, where if you are living in a wealthier area, you are more likely to be protected from these rising temperatures to some extent. This brings us back to our current conversation about our daily challenge of COVID. In these headlines from the beginning of the COVID crisis, we are presented with a reflection of the world trying to make sense of the end of whatever versions of normalcy with which we were once familiar. In May 2020, the New York led with the following headline: US deaths near 100,000, and an incalculable loss. This article shared 1,000 obituaries of people who had died. Now, less than 2 years later, we in the US have lost a conservative 947,000 lives. And we have experienced 78 million cases of COVID. 5.95 million people have died around the world. Beyond death, COVID peeled back the layers of inequity that are so comfortably baked into our society in the United States and highlighted which aspects of our culture facilitated the creation and maintenance of structures that supported our malaise at addressing these inequities at all. One aspect of this pandemic that we must acknowledge is that people across the country actually experienced the rise of COVID cases at different moments. This graphic was taken from CNN.com and is based on data out of Johns Hopkins from June 2020. And what you can see is that areas that first struggled with the rise in the virus, like New York City, were suddenly doing better for just a small pocket of time. And places that had been shielded from the trauma of that early emergence of this virus were suddenly held firmly in its grip. Basic governance in the United States allowed for states to develop and enact their own policies and protections, or lack thereof, against COVID. This diversity in policy and practice, under the guise of freedom, rendered us actually more susceptible to this infectious disease, which can mutate and shift and change as it moves through space and time. Data from the National Conference of State Legislators, reveals that the high variability in the application of federal guidance regarding COVID. And that variability in the application of federal guidance also mirrors variability in the experience of this pandemic. So what did we learn about the end of the world from the early days of COVID? And these are pictures from the New York Times, Reuters, the University of Chicago, and ABC7.com out of California. One striking takeaway from my perspective as a biological anthropologist who studies social and kin networks, risk and vulnerability, and individual health outcomes was that our commitment to bootstrap ideologies about individual perseverance and freedom were not going to serve us well in the face of a highly contagious infectious disease. And in fact, the lack of a formalized safety net and protective procedures for the most vulnerable individuals in our communities ensured that we would experience this end of the world quite differently depending on occupation and position in the social strata. And so in this, if you aren't remembering, these are pictures actually of morgue trucks that were lined up in New York City as cases surged at the very beginning of the pandemic. And I wanted to highlight in this slide what we were calling essential workers or frontline workers, individuals who could not stay home, who had to work through those early days. And if you remember, in the very early parts of the pandemic, there were lots of celebrations for frontline workers. We were applauding outside hospitals at 7 o'clock every night when shift changes happened. But slowly that support, which was kind of in feeling only, not in policy, started to ebb. And in fact, 1/4 of frontline workers have had trouble affording basic expenses during the COVID-19 crisis. So while we have all been impacted by COVID, some have been impacted more than others. While there are frontline workers who are thinking quite a bit about how to survive every day and protect themselves, there were many discussions about sourdough starters, and I do not take myself out of this conversation. And we can talk a little bit, maybe in the Q&A, about positionality. But certainly I was able to work from home, so there were conversations about things like sourdough starters on all these websites and little articles about how to do these things at home that we never had time to do. There are also ongoing jokes about wearing an outfit that looks really nice from the top up so you could be presentable on Zoom, whereas you're very casual from the bottom down. And finally, conversations started to emerge that working from home is in fact a privilege. And so when they looked at the share of US respondents in this one study who worked from home more because of the coronavirus by annual household income, you found that 45.3% were making over $200,000 a year. In a New York Times opinion piece by Charles Blow entitled "Social Distancing and a Privilege," he cites data out of Chicago that showed that 70% of COVID-19 deaths were deaths of Black people, and pointed out about surrounding Cook County that, quote, while Black residents make up only 23% of the population in the county, they account for 58% of the COVID-19 deaths. And in fact, we know that while COVID deaths are not experienced evenly across communities, neither are the tolls of the way that this pandemic was handled. According to a report by the National Women's Law Center and mentioned in a piece by Rebecca Clay for the American Psychological Association, Women in the US have lost 5.4 million net jobs since February 2020, and globally women's employment dropped by 4.2% as compared to 3% for men. Additionally, the report above, all of the jobs lost in December were women's jobs. The leisure and noted that the leisure and hospitality sector lost 498,000 jobs in December 2020, and women accounted for 56.6% of those jobs that were lost. So, you know, even if you were able to work at home and you didn't experience job loss during the pandemic, we still had all these other ripple effects that kind of emerged. And one of them were the kind of immediate and long-term impacts of the COVID-19 pandemic on the delivery of surgical services. So in this article out of the British Journal of Surgery, there's a discussion about how to kind of strategize around reducing elective surgeries in any given hospital based on what the case count looked like for COVID. And this article was first published in April 2020. And at that time, clinicians were already concerned about how to figure out which surgeries could be delayed, which ones needed to go forward, and how to think about that in light of COVID. This pandemic revealed what I call a care crisis. Unlike other countries, most notably Taiwan and New Zealand, the United States as a whole had few mechanisms in place to protect individuals, reduce risk, and support those who were faced with COVID infection. For biological anthropologists like myself, this inability, who study kin and social relationships, this inability or unwillingness to truly confront this challenge via a deepening of support rather than a go-it-alone ideology was an obvious failure in governance and a clear effect of American myth-making about rugged individualism. From an evolutionary anthropological perspective, caretaking requires an exchange of energy and resources, an investment in social relationships, expectations of reciprocity, and these context-specific yet reliable relationships have been the difference between life and death, and more subtly, survival and thriving for millions of years. In classic studies of investment, we tend to think about things like this, what I call like the maternal triad, right? Which is the production and release and eventual fertilization of eggs, pregnancy and lactation. These were the spaces with which we would focus lots of energy when we were thinking about building social networks. We would begin here as this being the most kind of primary relationship between individuals in any society. Indeed, when we examine the most influential work on parenting and parental investment and kin investment, or even do a Google perusal of the portrayal of parental investment in anthropologically related sources, parental investment is often revealed as something that is best understood via the lens of foraging and small-scale agricultural communities. In my own work, I've asked why we are not asking these same questions in urban and semi-urban industrialized communities. I've been studying what we can learn about these most critical care relationships and their embeddedness within larger communities beyond that of a traditional anthropological subject. COVID and our response to it has underscored the urgency of revisiting our practices as both a discipline and a broader community, and our understandings of community and investment. As a faculty member at Arizona State, I have learned how the Navajo Nation has both suffered from the spread of COVID in their community and also battled back in ways that the surrounding areas in Arizona were simply unwilling or unable to do. In mid-2020, the Navajo Nation had the highest per capita infection rate of COVID-19 in the United States. Although the infection rate remains high, tribal leaders continue to practice mitigation efforts, while many parts of the US have simply relaxed restrictions. So what does care look like in this context? It looks like close attention to the needs of the community, including the most vulnerable. So central sites for the distribution of resources, like groceries and medicine, vaccination efforts, mobile clinics to serve far-reaching communities and those who are unable to travel to central distribution sites, curfews, required masking, persistent lockdowns. And as of December 2021, 59% of the people living on the Navajo reservation were vaccinated, as compared to 54% of Arizonans not living on the reservation. Similarly, New Zealand dealt with the coronavirus in ways that other countries were simply unable to do. And this also included lockdowns, border controls, and persistent policies that required vaccination and masking. And to that effect, we know that rates in New Zealand have been much lower than they have been in neighboring countries and in countries around the world. So when I think a bit about an anthropology of investment and how it relates to ideas around COVID, I think about why the kind of limitations of our imagination with regards to policy in the United States and what our stumbling blocks are there, and how we need to think about policies that can deliver care at scale. And I'm not sure, and I would love to talk about this in the discussion, what it would take to shift us as a community to a space where we would start to invest in each other beyond simply our neighbors or our families. And we don't even do neighbors very well, truth be told. So the one thing I want to say in closing here is that in those kind of archaeological examples of collapse, the thing that I want folks to remember is that collapse doesn't mean everyone dies and goes away. It means there's a death of what was once there and a rebirth. And it also doesn't mean that everyone survives this transition. But as I mentioned at the beginning of the talk, zombie films are so alluring because they have the ability to both highlight a universal level of vulnerability while also employing a metaphor that uses zombies to highlight the themes of invasion and difference. In this moment of climate change, new and old wars, and COVID, the end of the world will not be experienced similarly for everyone across social strata. So what are the lessons that we can learn from the anthropological record and from our peers around the world? One, which should be blatantly obvious, is that inequity is unsustainable. It cannot persist, and community will not survive a persistent inequity. Inequity is violent. It's structurally violent, and it is directly violent. And it's also costly. And it costs everyone, including the haves, and not just the have-nots. We're probably going to have to do some serious work reimagining our relationship to others and understanding our own vulnerability and risk. I think one of the biggest challenges facing us with regards to COVID is a lack of identification with others who are experiencing different levels of vulnerability than ourselves, and in the recognition that we ourselves may experience different levels of vulnerability at different points in time. We also need to invest in shared community. And I think that some of this is going to have to come in the form of things like mutual aid projects, because we're not in a space as a country where this happens at a policy level in a very easy way. And then finally, I'm hoping that out of COVID and out of all this information that we have about the way that the toll that COVID took on our community, that we can advocate and agitate for care at scale. And what I mean by care at scale is rethinking the way that we kind of our kind of fetishization with individualism, and thinking a bit about enacting and agitating for policies that allow for better protection of people at all levels of social strata, and particularly the most vulnerable. I want to thank the New York Academy of Sciences, Dr. Stephanie Rupp, Christina Baines, and Bayard Campbell, and Luseadra and Aunchalee for joining me.
So I just want to start by saying the most heartfelt thank you to the absolutely amazing Dr. Robin Nelson for inviting me to be a part of this discussion, this conversation, and especially to be able to do so in the company of the equally amazing Dr. Aunchalee Palmquist. I've been admiring Robin's work as well as her general approach to the world, mostly from afar since I think 2012, 2013, or thereabouts, when I first saw her give a talk on alloparental care and kinship. But aside from maybe two very fleeting wave at each other in the hall encounters at conferences, I haven't actually had a chance to really talk to her. So this is really just such an amazing opportunity. And I'm trying not to be too starstruck, but I don't know. I suspect I'm not being, that's not terribly successful thus far. Also, thank you really to the NIAS folks for putting this together and making it happen so that the three of us could be together with all of you. There's more than 80 of us here in the room, in this virtual room, so that's really wonderful. I don't know exactly how much to say about my background. I know Christina already introduced Aunchalee and I at the beginning of the session, and how much to say about my research foci. So to give like some context for the couple of comments I want to make about what some of my own reflections on care and crisis. But maybe I'll just say a couple of a few lines, because I know some people came in a little bit late. So I think I will say that I am an evolutionary anthropologist by training, and to a large extent really by intellectual passion too. I started out, it feels like a million years ago, really nerdily interested in Neanderthals and what weaning might have looked like in Neanderthals. But somewhere along the line, maybe about halfway through my PhD, which I finished back in 2016, I started looking around both at my own life. It was, I guess, probably actually when I was pregnant with my first daughter, particularly. And at the bigger picture and thinking, I have been lucky enough to get some resources to examine and to think deeply about things, about human variation, and shouldn't I channel those resources and that luck into thinking deeply about things that might help people address some of the real world problems that shape their lives right now, including some of the people in my own network. And where I landed at eventually was using some of my perspectives, knowledge, maybe even methodological tools that I gained from training as an evolutionary or a biocultural anthropologist to try to shed some light on emerging non-communicable disease epidemics, and on the structural inequities that likely drive them. And I got particularly interested in metabolic diseases like type 2 diabetes. I think that explaining how I went from wanting to disrupt cycles of inequity in non-communicable diseases to some of the main organizing principles and hypotheses that now drive my active research program, which you just heard a tiny bit about, is probably something that we don't have time for. So I'll skip that and just say that I frame basically all of my research now in terms of what's called the developmental origins of health and disease hypothesis, which basically holds that environmental inputs, things like a lot of the things you just heard about in Robin's talk, things like air quality, climate, stress, nutrition, infectious disease, but then also on the positive side of things, other sources of resilience, nexus of support, care, beauty, during all those kinds of environmental inputs during the early stages of life, like pregnancy, cue in embryos or fetuses or babies' development in ways that influence and their chances of survival in the immediate term, but they may have negative consequences a little farther downstream, particularly in middle adulthood and beyond. So that's the frame in which I approach my work, and it's brought me sort of the long evolution about thinking through that lens and thinking about structural inequities in health and non-communicable diseases led me to launch the SPOONS project that I'm running now, which SPOON stands for Supporting Pregnancy, Food and Nutrition Security in Denmark's Most Marginalized Neighborhoods. And it's basically a community-based research program aimed at understanding how care and cooperation shape nutrition during pregnancy, and also what some of the structural factors like fairly racist. It's if I hope I get a chance to flesh out some of this a little bit in the subsequent discussion and Q&A. Housing policy plans here in Denmark, how those things might making getting safe, adequate, and appropriate foods inaccessible or challenging for many pregnant people, regardless of what their care networks and support networks might look like. So that's kind of who I am as a researcher in a nutshell. I kind of lost track of time, lost track of how long I've been talking. I should give it over to Aunchalee.
I prepared slides just to help keep myself organized, but I will admit that they're a little bit all over the place. So hopefully we will have some common threads and we can pick up on the discussion, which I'm really excited to learn more about your work, Luseadra. So I'm going to kind of start here with thinking about the evolutionary origins of care and investment in the perinatal period, because that's the period that I sort of focus on in my work. Sarah Blaffer Hardy, in her book Mothers and Others, has written that shared childcare may be the secret of human evolutionary success. And she notes, quote, "From a tender age and without special training, modern humans identify with the plights of others, and without being asked, volunteer to help and share even with strangers. In these respects, our line of apes is in a class by itself." It is hard to overstate the human need for communal care during and after pregnancy and throughout infancy. And these are significant and deeply connected to our evolutionary history. These needs cannot be neglected without consequence. And when they are, it is often catastrophic, both for people across the life course and generations. So as anthropologists, when we conduct sort of these cross-cultural and comparative studies of practices around the perinatal postpartum period, we can see that there are some common things that both nurture health and survival of mothers and infants, such as immediate skin-to-skin contact, initiation of breastfeeding, shared sleep between the mother and the infant, rest of the postpartum parent, having someone to feed her and watch over them, and also having rituals for postpartum care that support psychological, social, and emotional transitions that all come along with this event of bringing new life into families and communities. Lactation is also particularly significant. So making milk is one of the key defining characteristics of humans. It is also one of the most ancient. Ecological and evolutionary perspectives are critical to understanding both individual, community, and population variability, including the diverse and complex ways that human milk has helped humans adapt to life on this planet across time and space, including in the face of emergent infectious diseases and disease outbreaks. So this is part of why early in the pandemic, many of us were deeply concerned about national policies related to the mandatory separation of newborns from their mothers if COVID-19 was suspected or confirmed. Mandatory separation policies were in fact contrary to the WHO guidance and was enacted in the United States by the CDC and the AAP and then quickly adopted around the world without regard to the consequences of isolation and disruption of care, violations of human rights during childbirth. At this time, there were no vaccines and no medications, and it was not certain what the transmissibility of the virus would be through milk. But it was suggested that there was really no good evidence that separation was actually needed. And despite that, mothers across the world were, and continue to be, denied the opportunity to have a support person with them during labor and delivery in hospitals, denied the opportunity to have skin-to-skin contact, to bond with their infants, or to breastfeed. As Zanita Thayer, biological anthropologist, sort of outlines this in her Sapiens article here. And infants are deprived of skin-to-skin contact and breastfeeding despite the lack of evidence. So this mandatory separation of mothers and newborns has indeed led to excess preventable illnesses and deaths among infants and women around the world. So this is one example of how policies can be enacted in ways that disrupt the basic things that we need most, which is care and support during a really vulnerable and sensitive time of life. The toll of the collapse, the different dimensions of collapse that Dr. Nelson mentioned earlier, whether through climate emergencies, disasters, or emergent infections, are not experienced equitably, both in terms of labor, employment, social status, racialization, and structural inequities. There are also biocultural considerations, as I mentioned, for this population. So humanitarian crises in particular account for over 95% of the global burden of maternal mortality and over 50% of the global burden of under 5 mortality. as well. So an estimated 90% of infant deaths that occur in humanitarian settings occur in the first 28 days of life. So there are other impacts as well. Recently, there was a headline that over 5 million children around the world have lost a parent or a caregiver due to COVID-19. And in the United States, we know that there is an increased burden of mental health issues among children and adolescents, exposures to neglect and violence, and education loss, among other things, also not experienced equitably and the same across different populations. I've often reflected on how my own witnessing humanitarian crisis seems to bring together the best and the worst of humanity, sort of all together. And too often in these situations, the beginnings and the endings of life collapse upon one another in ways that I have found disorienting and challenge my perceptions of time and space. And so just by virtue of some other things that I've been working on and reading, I'm bringing in some other insights from some essays from this volume of Feminist Africa on Afrofuturism. And in this essay, Mina Salami talks about the liquid space of African feminism and Afrofuturism, which resonates with my reflecting on the coloniality and the temporality of this crisis. She writes that rather than being linear, the passage of time is like a course of a river that swells and curves forwards, downwards, yonder and sideways in response to circumstances within and beyond its streams. This confluence she calls a liquid space to reflect a place of uncertainty. So my question is this also a place of hope? As Dr. Nelson mentioned, is there a space for imagining new systems built upon care and for radical kinship? Dr. Nelson has illustrated the coloniality of COVID-19 and in responses to it, not only in the US, but in other places around the world, which commonly minimizes care over capital or profits. The structural violence that is unleashed as a result of racial capitalism during crisis like this pandemic targets our human dignity by disrupting pathways to care and making care only available to some, usually the privileged. Lada describes this as a polycrisis, or convergence of ecological, political, spiritual, and social breakdown, where the quote unquote traditionally held certainties of humanity's place in the world are crumbling. Lada and others across the global South affirm that the only way forward from this kind of crisis is deep solidarity, grounded in care and fighting against the oppression and exploitation of those who are most marginalized. In reflecting on the possibilities of imagined futures where care and human dignity are centered, I thought I would share Sylvia Tamale's invocation of Ubuntu as a reconceptualization of justice rooted in shared African worldviews and philosophies of being. In her new book, Decolonization and Afro-Feminism, she notes that, quote, Ubuntu emphasizes good human relations within meaningful human life. As a pathway to justice, Ubuntu is more than equality. It is about leveling the ground by addressing systemic injustices and trump the dignity of human worth of the marginalized. So as Dr. Nelson wrote in her Scientific American piece, rugged individualism will not save us. And it is not an understatement to say that the future of humanity will hinge on our collective ability to honor our evolutionary mandate to care for one another and our planet.
Thank you so much to all three of you, Drs. Nelson and McKerracher and Palmquist, for those provocative ideas. I'd like to invite you to enter into a conversation. We can be relaxed, and there's many threads to weave. While you're speaking, we're going to invite the audience to enter questions into the chat. I'm sure there's many ideas that they may have, but perhaps this is a good time to bring it back to you, Robin, to respond to some of the comments. Luseadra.
Sure. And I think, one of the reasons why I was really interested in having this conversation with these two scholars is because their work is on that most pivotal period of vulnerability for parents and young offspring. And I really thought that it would be, COVID presents us with unfortunately, like a crisis point. Like this, you know, I think what Luseadra and Aunchalee already know is that this period in like kind of perinatal or pregnancy is a crisis point almost all the time. Like, I mean, it requires a tremendous amount of resources for it not to be a crisis period. And so when you're in different, you know, care settings, you kind of realize different levels of vulnerability for people in this particular space. I wanted to know, I'm wondering in both of your work, like what your experience with anthropology, the work that you've done, can tell us about risk and survival and who is getting help. And both of you have looked at kind of like national level policies and kind of risk and humanitarian crises. So what has become apparent to you in these spaces?
I can start, I think. It's such an important question. And I think I'm going to maybe pick up on something that you raised earlier, Robin, about I guess also you touched on this, Aunchalee, about the US being such a pull yourself up by your bootstrap sort of place, a place with bootstrap ideologies, I think was the phrase you used. And I haven't lived or worked really in a context like that exactly. Most of my life I've spent in Canada, which is in many ways culturally very similar to the US. Demographically, it's not as diverse, but it's a multiracial settler colonial state with some of the same ways of organizing things, but it is also a social democracy with healthcare resources and at least an idea of prioritizing care and supporting the vulnerable. The federal government doesn't always put its money where its mouth is, although I think generally it did a pretty good job of responding to the COVID crisis and spending really a lot of money to support care workers. Not enough. I don't think there was quite enough investment in nursing and particularly in early childhood education. The federal dollars were there, but it wasn't really implemented as well as it could be. And then I'm married to a Dane, and I've spent the last couple of years in Denmark, which is sort of like the next level of what I grew up with in Canada. And it's a really, really comprehensive state-sponsored attitude towards making sure that there are resources for people, generally speaking. That being said, in Denmark, that is not the case when it comes to immigrants from quote unquote non-Western backgrounds. They are second-class residents very, very, very much. So there are a lot of people that in general fall through the cracks, and COVID absolutely sort of laid those fault lines bare. And the neighborhood where I live in, for example, is a predominantly non-Western immigrant neighborhood, and it's on what the Danish government, until it got a lot of international criticism, formally called the ghetto list, which is a list of roughly 30 neighborhoods with relatively high rates of poverty and unemployment, and at least 50% of the population has to be of non-Western background to be on this list. So I live in one of these neighborhoods, and the population is about, I don't know, I think around 3% of the city's population. And the neighborhood makes up about 3% of the city, but it accounted about for more than 40% of COVID cases at some of the peak waves, which I think illustrates that even though there are financial resources here, even though this is a society that says that it cares and invests in care, it doesn't do so equally, which was sort of the point that you were making. Those are, I don't think I actually answered your question about what I think being an anthropologist meant that moving to Denmark and observing that means that instead of just being in the daily rhythm of listening to people's the daily rhythm of life, I think I probably have some sort of sense of a need to look at what policies are in place. And I think, I think I wouldn't have I don't think I wouldn't live in the neighborhood that I live in, and I wouldn't have the interactions that I have had or the perceptions that I've had if I didn't have the training in the background that we all do.
Yeah, I mean, I think it's clear that policies do have some kind of influence on what happens, but usually, I mean, I feel like in the case of the CDC guidance directly contradicting the WHO guidance, for example, does so in sort of predictable ways that perpetuate inequities and disparities. I mean, the United States is already a really, really hostile place to experience pregnancy and birth and to raise children. And I think the fact that the CDC and AAP came out with these early recommendations led to a really swift adoption elsewhere in places where there would have been more willingness to keep infants together with their mothers and to support breastfeeding, particularly when there weren't, vaccines, and there wasn't really a lot of evidence to suggest that those things might be super dangerous. So I think I'm of the mind that there is, in terms of scaling up, there's a potential for policies and more, governance to help move the needle towards more equitable care and providing social structures that give people what they need when they need it. But I'm also skeptical because I know that there are, for example, in the humanitarian response for infant feeding and emergencies, which is the sector that I'm more familiar with. Humanitarian response perpetuates the same kind of racialized neocolonialism and harm and violence that in some ways replicate or just exacerbate the other kinds of shocks, whether it be a war or a natural disaster or some other kind of displacement. I mean, the kinds of things that I've seen in terms of country level or international level humanitarian response are appalling. They're there to in the spirit of protecting human rights and protecting the well-being of women and children during this perinatal period, and they're just causing so much more harm. So I think that I think there are people who are more expert in understanding what possible political solutions there might be. I think ultimately we probably would agree there needs to be massive divestment from this humanitarian industrial complex, racial capitalism in general. And I think that those to have that sort of social shift in a way that begins to move policies and to move institutions in that direction probably takes a revolution. It takes a long time. And I think, just sort of where we're at now, I want to invest in hope and to sort of move, mutual aid works. It is what allows people to get the help that they need, not equitably usually, but it is sometimes the only thing that we saw it during COVID-19, where you had doulas and community midwives and community health workers trying to get PPE so they could go visit folks in their community and do whatever they could to telehealth, WhatsApp visits, and trying to do anything to overcome the barriers that our healthcare system was putting up in the early parts of the pandemic. So I think I don't have the solutions, but it's definitely not it's not what we have been doing. It's definitely not the divestment of public health and public science education and all those things. In terms of anthropologically speaking, I mean, I think anthropology just has helped give me the tools and sort of the words and the ideas to kind of understand these inequities and understand like they have a history. And just as there are histories in terms of the racism that is perpetuated through these kind of crises of colonialism, that there have always been people coming together and finding ways to provide each other with the care that they need, because that's what we have to do. So they're I guess that it's sort of like that critical perspective, those tools to sort of think through both an understanding of why we get here, and then what do we do now?
Yeah, I've been experiencing the pandemic and concurrent crises as kind of this ultimate experience of living through something while being on this level of being a social scientist, where you're also thinking about it in critical ways while living through it, which is exhausting mentally, right? Because I mean, on a certain level, we're all just kind of hanging in, and particularly if you have, family you're caring for, or your own job is particularly vulnerable, there's a survival piece to every single day that is, heightened in a crisis. And one of the things that I couldn't seem to, and maybe this is naive, like admittedly so, that I couldn't seem to make sense of, and I saw someone tweet about this as well, is that, when we watch, and the reason why I reference zombie films, no one runs towards the zombies. No one runs towards the virus. Everyone runs away. You're running away. You're hiding. The thing that has kind of broken my heart and brain about this particular crisis is the lack of acknowledgement of one's own real vulnerability. So the way that we talk about comorbidities right now, well, you'll be okay with non-masking if you don't have any comorbidities. I don't even think all of us, we have a terrible healthcare system. Who actually knows what all their comorbidities are? People are not even, out and about and kind of maybe, when's the last time your blood pressure was checked or anything like that, right? So there's this kind of lack of acknowledgement of one's own risk, but then also kind of flippant disregard for anyone else's risk as well. And those two things combined, and now I'm living, I moved from California and now I'm living in Arizona. And those are very different spaces with regards to policy and kind of public attention towards risk. And I think that I, as an anthropologist and and anthropology isn't maybe the most important metric here, but it has shaped my thinking on this, that I wasn't necessarily prepared for people to put themselves at risk and be so, I think I was okay. I think I understood some of the kind of disregard for frontline workers, disregard for, because that fits right into our kind of racialized capitalism within the United States. But a kind of overestimation of one's own health is such a revealing factor, a revealing kind of insight into the stories that we tell ourselves about how interdependent we are. We have experienced pandemics in the United States before. It's been a while, but we have experienced them. And I think, watching people kind of feel like they're fine and they're not going to be concerned about anyone else. How many stories did we hear about people who on their deathbeds were regretful that they hadn't taken different precautions around COVID? There are things that we can say about care and community that are very relevant to all of our work. But I think there's another layer, of course, which has to do with kind of class and kind of ableism and racism that doesn't allow us to kind of get to those core kind of human behaviors that emphasize class. I'm wondering, in each of your work, what have you seen to be kind of the most, if we acknowledge that policy has holes and that it doesn't really, policy isn't going to fix everything, because like you were saying in the Denmark situation, that it's, quite racialized, right? Who is able to kind of get care, and we know what happens in humanitarian crises. What care counts? Like, what policies are actually effective, or what kinds of mutual aid projects have been effective in the different settings where people have been most vulnerable in your own research?
Well, here in Denmark, in particular in the neighborhood Gellerup where I live and have been doing my active research project, the only thing that really works is this. It's not a mutual aid organization, but it's this network that called Buddhasmor, or neighborhood mothers, and they're not necessarily mothers, but they are predominantly, maybe exclusively, women, mostly middle-aged, and it's not entirely clear to me exactly what this organization started out being about, but it's a national thing with local chapters, and the local chapter where I live is all people from the neighborhood that speak the languages of the native languages of the people who live here, the mother languages of the people who live here. And what they seem to do, and particularly what they've been doing at a sort of like a next level in the context of COVID, is just to meet people where they're at. And they literally knock on doors of all of the people who live in the social housing blocks in the neighborhood, and they say, did you know we exist? We're here. What do you need? Have you read anything about this? Did anybody make this accessible to you in a language that you understand? What's been your experience? Are you afraid about this? Do you misunderstand that? Can I go with you to get a vaccination, for example? Can I walk with you to your appointment with your primary care physician? What do you need? Do you need food? Do you need these resources? And people actually buy into that. There are also a lot of state resources and that are also invested in these so-called vulnerable neighborhoods or ghetto neighborhoods, but there's no uptake. They just sit empty. But the Buddhasmor, people connect with them. They use them. They build relationships with them, and then they actually get their healthcare needs met. They get their social needs met. They meet other people through these women. So that really gives me a lot of hope.
Yeah, I was thinking a lot about since Dr. Paul Farmer has passed away, a lot of people have been talking about, this accompaniment model that was so intrinsic to the approach to care that he kind of brought to partners in health. And I think what I've just heard Luseadra say, and what I have seen is it's precisely that kind of model of care that seems to be the most important, particularly for pregnant people and those who are caring for a new infant, is just having someone to go with you, like you said, someone to check up on you, someone to bring you food, someone, even in the I was involved in this telehealth access project during the first year of the pandemic in the US. And there was all this investment in these new innovations and technologies. How do we get people connected to telehealth services and remote care, and sort of bridging that gap between the hospital and community. And we interviewed Black birth workers and Indigenous birth workers and other community health support persons working in communities of color and rural communities across the US. What they said was telehealth is great, but we don't need a technological innovation here. What we need is PPE. We need transportation support. We need to be with people, because for lots of different reasons, but there's so much to the sensory dimensions of care during pregnancy and postpartum that even sort of the idea that you couldn't put hands on someone to sort of check the pregnancy or to, sort of see what was happening during breastfeeding, to sort of look at the color of the baby, and, just sort of that assumption that technology was going to take us, sort of lift us out of a crisis, when actually it was really that human connection. So I don't know if I'm speaking in ways that are really clear, but I think just that the things in terms of what I have seen both during COVID-19 and other settings is actually, it's that very, very deep human connection and compassion, and sort of being with people, not just, and finding ways for policies to make that possible. I mean, we don't have the community health worker system that we really need in this country. And I'm not exactly sure, I don't know the history, I'm not sure why that is, but if we had invested in those kinds of care, we would have been able to mobilize birth workers and midwives and nurses and other folks, vaccination clinics, like much more readily across the nation, to do education, to do community engagement, to do all those things, and have accompaniment models to ensure that people weren't falling through the cracks. So I guess in a nutshell, that's sort of what I think.
Yeah, I mean, I was thinking about this because, part of the reason, I'm in Arizona, and so the example of the Navajo Nation is right here, and ASU has worked in relationship with the Navajo Nation, and one of the kind of very interesting things is that, like, if you are on the reservation, like you have to abide by their rules. This is about sovereignty, right? And so some of the kinds of thoughts that have kind of come to my mind is thinking about the way that we respond to crisis and how we see vulnerability in our relationship to other people. And so if you're in a space where fundamentally the relationship to community is different, Arizona is a very, live free or die. I know that's New Hampshire, but it's a very live free and die kind of space. And if you're in a space within Arizona, that's where people fundamentally organize themselves differently in relationship to one another. What does that look like as COVID kind of peaks and dies down again, and peaks and dies down again? And how do you respond to these crises? And I think, in watching all of this kind of social media conversation about the end of the world, I just got to thinking about how many people are experiencing something like the end of their world very frequently. Be it kind of forced migration due to crises, be it dissolution of kind of family support systems, whatever it is, this has been part of the human experience. And the only way that we've seen ourselves out of it is through increased investment in one another, not through dissolution of these relationships. And I really appreciate your point about the fact that tech is not going to save us. Because I think there is this kind of, at every level, right? Not to kind of go off on a bit of a tangent here, but even this concept of like biohacks, I don't know if you've heard of this, is like things that tech, mostly tech guys, I was trying to think about if I could say that, but it is mostly tech guys, like, think about doing to their body to kind of maximize efficiency and maximize performance. There's always this idea that there is a hack that's gonna get us out of the most basic everyday needs in our relationships with one another and our daily needs in terms of life. If I do this, I only need 6 hours of sleep. No, you probably need 8. Not all of us get it, but your body actually probably needs closer to 8. There are just parts of our lives that I think we can speak to as people who are interested in health and interested in inequity and interested in sometimes in deep time, that we know are pretty stable. And so when we kind of violate that, certain people are put at risk more than others.
I think even to some degree, with the idea that the vaccines are now, that's all we needed was an effective vaccine, and then we'd be good. I think there is some definitely over reliant, but I think that grows out of this more like sort of capitalist kind of model. This, the idea that we need to profit off of crisis in order to sustain our society in like particular ways. And I think it also feeds into those ideas that you were talking about. I mean, I even had family member tell me, I have an immune system. God gave me an immune system. Why do I need, why do I need this vaccine when I don't know what I'm putting in my body? So this idea, there's really different kinds of ideas about, it only matters, I'm only thinking about me and how it's going to affect me, not, well, maybe I'll transmit it to someone else, or maybe like I'll die and my child won't have a parent anymore, or like this, those things weren't even sort of in this particular conversation. But yeah, there's just so much of that happening in terms of policies, like the masking policy. I mean, just the rhetoric that kind of, I understand it, and yet I don't understand it. It's sort of like, I think that's part of this, like being in it, where you're trying to like understand it, but like you're living through it. It's like how I don't understand the logic sometimes, and yet we have tools to really kind of understand the origins of that kind of rhetoric and those kinds of ideas.
I wonder if there's some possibility for some people reframe. I'm just have been percolating. I don't know how to frame this point exactly, but the point that Robin made about some people's inability to sort of or probably most of our inability to really assess our own health risks accurately, and to maybe take risks that we wouldn't if we, even from a purely self-interested perspective, because we don't know necessarily what's going on under our own skin, or haven't fully thought through all of the consequences. And I wonder if there's some way of reframing, protecting, minimizing one's own risk, and in a way that's sort of that is fairly individualistic, is a way of motivating something that would actually have ramifications for and benefits for a larger network of people.
I don't
didn't
think
make
you're
the
wrong.
point clearly at all.
No, I don't think you're wrong. And Stephanie was saying that, that we have very contested layers of experiences and identities in places like the United States and Denmark. And so there's not a shared solution because there's not a shared experience, right? Like it's the way the society is structured. And I have thought about this, that unfortunately, we have not cultivated a ethos of care across space. And in fact, we've encouraged just the opposite. Our countries have thrived off just the opposite, right? That some people are going to be winners and some people are going to be losers. And those kinds of positionalities have been kind of locked in for hundreds of years. And I think that I've thought about this kind of self-interested approach. And I think that it probably does work in some ways, and then that's kind of painful to me, that's the way that it works. And so so someone says here, do you want to do it?
Oh, do you want me to? I mean,
you can, please.
Yeah, Merav has a question in the chat. Thank you all for your thoughtful and engaging and compelling talks and remarks. They are very aligned to the insights and commitments of critical medical anthropologists. And I was just thinking the same thing. Mm-hmm. And others concerned with documenting, denouncing, and trying to correct and eliminate social injustices and provide a more equitable lifeways for all instead of just the privileged few. So the question is, she's curious what unique insights biological anthropologists bring to this conversation. So
I guess I would say that I think that, one of the things that biological anthropologists do that is a little bit different than our peers who are interested in the same questions in critical medical anthropology. And sometimes it's not different. I mean, sometimes our work overlaps quite a bit, in fact. And I think where you see difference is kind of methodological. It might be in some of the theories that we apply. But I think that a recognition of kind of the deep evolutionary necessity of these relationships is also important. because I think in some ways it speaks to the idea that there is no easy way around this or outside of this. That the being kind of deeply enmeshed with one another is part of the human condition and always has been for millions of years. And so there's kind of that viewpoint, which is a deep time viewpoint. But I think there's also there's kind of great literature out of biological anthropology that is actually kind of assessing on a kind of community-based level or a population-based level, just how impactful these relationships can be on the kind of survival and thriving of people within the community. I'm thinking, just kind of popped in my head of a piece by Barbara Piperata, which is looking at kind of mental health in the postpartum period. And she did kind of mental health assessments of women. And it was really kind of like, if the cultural norms around support with mental health were met in a postpartum period, women were thriving and their babies were thriving. And I think that what these two perspectives of like critical medical anthropologists and biological anthropologists, depending on the topic, they can kind of fit like lock and key, where we're talking about it from two different methodological standpoints. And for me, as someone who is interested in questions around advocacy, that's important because different perspectives agitate and meet people at different places. And so sometimes people want to see numbers and they want to know, this is really going to make a difference. Tell me how this makes a difference. So you come talk to folks who have been doing these assessments. Sometimes people want to think kind of big picture, pull back and talk about theory, and other researchers can do that work. So I think that is kind of the way that these types of work fit together.
And if I go so far to suggest, I had the same question, that I think that biological anthropologists are maybe positioned to have the ear of policymakers, whether it's because of their use of statistics and numbers, more so than medical anthropologists. Because I've asked this question a lot during COVID, like, why are we defining health as being virus-free and not as having a robust network of care? We know that this leads to health in ways that you've demonstrated in this talk. And I do think that we sort of privilege biology in some way. You know, if there's a social component, we think of it as less valid, and yet and this is something that I think we all fight against as anthropologists. I mean, I don't want to speak for everyone, but I think that biological anthropologists are maybe uniquely positioned to have that ear in a strong way.
And I think, like, really quickly, just to add, like, I think we do have to kind of be careful, because we don't want to slip into a kind of scientism where we like privilege certain kinds of data. But I think that we also have to be realistic about which data speak to particular people's motivations. And when it comes to the most vulnerable communities around us, I'm kind of willing to pull in whatever resources are needed, and whoever kind of understands the landscape best, regardless of your theoretical positioning or training, to kind of answer these critical questions.
There are also some issues that are really, they're biocultural, right? They require both an understanding of the social and cultural processes and exactly how those affect health, and how do we measure those, and how do we talk about those. So I think lactation, at least, is one of those things that's like, you can't really get around the biocultural feature of this process. And in that sense, I think absolutely being able to sort of craft data, especially if you're talking about advocacy and policy, that meets those needs of those the cases for greater kinds of advocacy, certainly be more useful.
I want to say thank you so much to our speakers this evening, Robin and Luseadra and Aunchalee. It was wonderful to host you and have you be part of our series on emergent care and community. Thanks to everybody for attending, and we hope that you all come back again for our next lecture, which will be on Monday, the 28th of March, again at 6:30, again by Zoom. Thank you, COVID crisis, for bringing us together, at least all across the world. Luseadra is joining us from Denmark, where it's super late, so we're so grateful to you for participating, even though the time zones are difficult. Our next talk will be presented by Dr. Vanessa Agard-Jones. She'll deliver a paper entitled Racial Capitalism, Chemical Kin, and she will be joined in conversation by Dr. Jafari Allen. So we look forward to welcoming each of you back with us to continue this important conversation about emergent care and community. So until then, be well, stay safe, and be happy.